Assalamualaikum and a very good day to my distinguished colleagues and fellow healthcare professionals. It is a great honor to be here today to share insights on a therapy that has significantly transformed the management of advanced heart failure, cardiac resynchronization therapy. Let me start off with what exactly is cardiac resynchronization therapy or CRT. CRT is a specialized form of device pacing designed to correct abnormal electrical activation and contraction patterns in patients with heart failure. In simple terms, it aims to resynchronize the beating of the left and right ventricles, allowing the heart to pump more efficiently. Unlike a conventional pacemaker, which usually stimulates one or two chambers, CRT stimulates both ventricles simultaneously, hence the term biventricular pacing. The main goal is to restore coordinated ventricular contraction, improve cardiac output, and relieve symptoms in patients with moderate to severe heart failure who remain symptomatic despite optimal medical therapy. Now, you might wonder why CRT is needed. Before I get into that, let me just explain what happens in a normal heart. Well, in a normal heart, the right and left ventricle pumps blood simultaneously, evenly, and synchronously and supply the body with sufficient oxygen. The pumping of the heart is controlled by electrical pulses and distributed synchronously through the right and left bundle branch. In certain heart failure patients, particularly those with a left bundle branch block, LBBB, electrical conduction through the ventricles becomes delayed and uncoordinated. This causes the septum and the left ventricle to contract at different times, leading to inefficient pumping, reduced ejection fraction, and worsening symptoms of fatigue and breathlessness. Such mechanical dyssynchrony not only lowers stroke volume, but also contributes to progressive ventricular remodeling and mitral regurgitation. CRT addresses this by restoring synchronized contraction between the left and right ventricles, thereby improving both mechanical and electrical efficiency. Now, let me get into the indications for CRT. According to guideline-based recommendations, CRT is indicated in patients with symptomatic heart failure, which is the New York Heart Association class 2 to 4, despite optimal medical therapy, left ventricular ejection fraction less than 35%, sinus rhythm, and a QRS duration of more than 130 milliseconds, preferably with a left bundle branch block morphology. This also includes a wide QRS complex. Special considerations are made for patients in atrial fibrillation or those requiring frequent ventricular pacing. So selections of appropriate candidates remains crucial to maximize the therapeutic benefit of CRT. Now, we're going to get into the components of a CRT system. A standard CRT system consists of two main parts, which is the pulse generator and the leads. The pulse generator, implanted subcutaneously near the clavicle, contains the battery and electronic circuit responsible for generating pacing impulses. Connected to it are three leads. One is in the right atrium, one in the right ventricle, and the last one is positioned via the coronary sinus to stimulate the left ventricular free wall. These three leads allow the device to monitor and coordinate atrial and ventricular contractions, delivering synchronized pacing pulses as needed. Now that we understand the components, let us explore how CRT actually works. During each cardiac cycle, the device senses intrinsic electrical activity and determines if there is a ventricular delay or block. If there is any detected, the device will deliver pacing stimuli simultaneously to both ventricles through its leads. This synchronized activation corrects electrical dyssynchrony, leading to more uniform ventricular contraction. As a result, cardiac output will increase, mitral regurg is reduced, and ventricular filling improves. Over time, this leads to reverse remodeling, a reduction in chamber size, and improved left ventricular function. In essence, CRT restores the heart's natural rhythm and efficiency, allowing it to pump blood more effectively. Now, the primary functions of CRT includes the first one being it restores electrical resynchronization by correcting conduction delays, particularly in the presence of LBBB. Next is mechanical coordination. It promotes simultaneous contraction of the septal and lateral walls. So when this happens, it improves the hemodynamics, which leads me to my third point of the function. It enhances the stroke volume and cardiac output and overall perfusion. So when your stroke volume, cardiac output, and also overall perfusion is at a normal rate, obviously the patients will have their symptoms relieved. So it alleviates the shortness of breath and fatigue and also improve exercise tolerance. Next is reverse remodeling. Like I said before, over months, CRT leads to reduced left ventricular volumes and improved ejection fractions. And when this happens, this will reduce in hospitalization and mortality. So several major trials such as Companions and also CARE-HF has shown significant survival benefits and reduced rehospitalization rates among CRT recipients. When we talk about CRT devices, there are two main types of CRT devices, the first one being CRT-P and the second one being CRT-D. So what's the difference between these two? CRT-P, or cardiac resynchronization therapy pacemaker, it provides biventricular pacing only, compared to CRT-D, which is cardiac resynchronization therapy defibrillator. It combines pacing and defibrillation capabilities together. So the CRT-D is preferred in patients at risk of sudden cardiac death due to ventricular arrhythmias, as it can deliver life-saving shocks when required. So selection between these two is individualized based on the patient's comorbidities, arithmetic risk, and also life expectancy. So our role as CVT during the implantation is that we assist in the lead placement by ensuring optimal positioning, verifying pacing thresholds, and minimizing phrenic nerve stimulation. So we monitor the ECG and hemodynamics parameters, document pacing data, and collaborate closely with the physician to ensure procedural efficiency. So post-implantation, CVT perform device interrogation, programming optimization, and follow-up monitoring to maintain synchronized pacing and detect any lead or device issues early. So our expertise bridge technology and patient care. It translates into a complex device data into a meaningful clinical information. To illustrate the profound impact of CRT, allow me to share a published case study by Khalid and colleagues in the International Journal of Clinical Cardiology in 2020. So in this case study, the patient profile is a 76-year-old male with end-stage heart failure. So severe coronary artery disease and also previous CABG presented in cardiogenic shock. His ejection fraction was severely reduced at approximately 20 to 25%, and his ECG showed a left bundle branch block pattern with a markedly prolonged QRS complex of 213 milliseconds. So, the multidisciplinary team proceeded with implantation of a CRT-D as a rescue therapy. Now you can see the difference between before CRT and also after CRT. While before CRT, the ECG showed a wide QRS, and also after CRT is implanted, it shows a narrower QRS with only 133 milliseconds. More examples of the before CRT and after CRT. This is in figure 1, it is showing a chest x-ray on initial presentation, which shows bilateral diffuse pulmonary edema. And also figure 6 shows that the chest x-ray with resolved pulmonary edema after implantation of CRT. So the outcome after CRT implantation, the patient is stabilized with improved kidney function, improved ejection fraction to 30 to 35%, and is able to restart guideline-directed medical therapy. So the key takeaway here is that CRT offers benefit even in critical end-stage HF when other options are limited. Now, while CRT offers substantial benefits, it is not without risks. Common complications include lead dislodgement, particularly in the coronary sinus lead, which may require repositioning, phrenic nerve stimulation causing diaphragmatic contraction or discomfort, pocket hematoma or infection, especially in immunocompromised or diabetic patients, venous thrombosis, and device malfunction or battery depletion over time. So, some serious but less frequent complications include coronary sinus perforation or arrhythmic events during testing. So preventive measures, meticulous implantation techniques, and vigilant follow-ups are the key to minimizing this risk. After CRT implantation, it is vital for continuous follow-up to ensure that the device remains effective. Device interrogation is typically performed at 1 to 3 months post-implant, then at regular intervals. Parameters such as pacing percentage, lead impedance, threshold voltages, and battery longevity are carefully reviewed. So echocardiography is repeated to evaluate improvement in ejection fraction and ventricular volumes. Equally important is also patient education. By instructing patients to report symptoms of dizziness, palpitations, or device pocket discomfort. As technologists and nurses, our collaboration ensures not only technical success but also holistic care. In conclusion, CRT represents a remarkable advancement in the treatment of heart failure. By restoring coordinated ventricular contraction, CRT improves both the electrical and mechanical efficiency of the heart, leading to better cardiac output, enhanced quality of life, and reduced mortality. This case presented by Khalid and his colleagues reminds us that even in critically ill patients, CRT can serve as a life-saving intervention when guided by sound clinical judgment. As cardiovascular technologists, our role extends beyond technical expertise. We are integral members of the heart failure care team, ensuring precision, safety, and compassion throughout the patient's journey. So, let us continue to apply our knowledge and dedication to advancing patient outcomes and supporting innovation in cardiovascular care. That is all from me today. I hope you had a impactful and also useful knowledge, and I thank you all for your attention.